I mean, that's a brilliant place to pause that. Thank you very much indeed for the moment. Well, obviously we've heard from the patients. Let's now turn our attention to the clinicians and the healthcare providers. Now, as you would expect, these individuals play a crucial role in guiding patients through their treatment journey, and they facilitate their involvement in managing their condition. Well, today we have the great privilege of hearing from two esteemed clinicians who specialise in the treatment of nasal polyp syndrome. Now, their insights into what we've been talking about, that shared patient care, shared decision-making, collaborative approaches to treatment planning, are really invaluable in navigating the complexities of CRSwNP and enhancing patient empowerment. Wytske, Professor Fokkens, really good to see you once again. You've heard their stories, and it's really interesting, isn't it, saying they had to push in terms of the shared care. I know that you are a brilliant physician and you involve your patients. How do you do that?
I see patients that always saw another ENT surgeon before they see me. I work in a university hospital. The first thing that usually happens, and can be quite difficult in the discussion with the patient, is that you have to explain that it's a chronic disease. And I always explain that it's the asthma of the upper airways. Most patients understand that asthma is not something I'm simply going to cure with another surgery. And then that is the start of the journey together to find at least control of the disease and hopefully remission and eventually cure.
And so when you tell patients this, what's their reaction? Because I assume when you talk about chronicity, this is a condition you learn to live with. That's not quite the message they want.
No, definitely not. You know, because they usually refer to, this is this great surgeon who can do it much better than I could do it, and she will solve the problem. And, well, my first message is, I will not solve the problem. And that's usually a huge disappointment, of course. And that's very, very understandable.
Professor Gevaert, does that sound familiar to you in terms of trying to talk to the patients? I mean, obviously you believe, both of you believe, that empowering the patients in this and giving them a voice is really important in how you plan the treatment protocol.
I always give them all the possible scenarios so that they can choose from. But the problem is, of course, that takes a lot of time to explain them what these are, and also the long-term planning of that. So say, you can do this, you can do surgery, you can maybe participate to a trial or get this drug. So you try to offer all the options and let them choose. However, that's very hard for them because they have to choose from themselves, and at the end, they understand that we are stuck in a difficult disease where you have no one solution that is working immediately.
And I suppose, Wytske, there's a level of understanding here as well, because if you set out all those treatment modalities, it relies on actually the patient having some understanding of what you're trying to say, the risks, benefits, and everything that's involved.
Exactly. If even a GP says, what sort of disease is this actually? What's the pathophysiology? What's the cause? Every patient wants to know, what is the cause of the disease? And of course, we don't know exactly, but we can explain a lot, like it's not an infection, it's an inflammatory process. That sort of things helps for patients to understand why you give a choice of potential treatments and where these treatments are directed to.
So just coming back to you, Professor, just in terms of setting all of those things out, is it always beneficial? Or is there sometimes an argument to say, my best advice to you is to do X, Y, and Z?
Yeah, well, that's the old style, saying, this is it, you have to follow this, and we will do that, giving them no choice. This is not how we work today. Patients won't accept that, and they are right. They should know the different options that are there. Although we have to realize that for us doctors, these options are also frustrating. For every year before, so the past 2 decades when we were working, we didn't have good options. We only had options like or surgery, or nasal steroids, or some rinsing. Telling do your
systemic steroids.
The systemic steroids, yeah, but we don't want to give them lifelong. So it was very frustrating to be a doctor, and I think that the patients really feel that when they tell all their stories. They feel that we are out of good options. We also didn't have the magic options that we really wanted to have.
And of course, Wytske, when just our panel here, they're all different backgrounds, different experience, levels of experience, whether it's clinical or what they've learned. And again, you have to tailor what you're saying to the level of understanding and how much they want to know.
Yeah, well, although, of course, you have to tailor the complexity of what you say to different patients, but I think in general all patients really want to understand what their disease is about. So I don't sort of say, oh well, you're too stupid to understand, so I tell you what's best. I always try to explain what disease is about.
And Professor Gevaert, this is a tricky question. What do you think you do well and what do you think you could do better?
I think I'm very good in explaining my patients what their disease is and what the options are. What I can do better, well, I think I still always have too little time. So my time slot is 15 to 20 minutes, and then next time they see me is 1 year later. So what I don't do well is I have no time. My time slots available for I would wish I would have more time for them, to explain them everything myself, but that's hard.
Of course. And Professor Fokkens, this is really where EUFOREA comes in, isn't it? Trying to empower the patient, to get them to ask the right questions so they come armed with knowledge. How does EUFOREA fit into all of this?
Well, what EUFOREA does is really, all the explanation I give can now also be found on the website of EUFOREA. So that's the first thing I now try, say to a patient, go there, look at the videos you're interested in, go to the written material and come back with the things you don't understand. And another thing I think is really important, I always ask my patients if they want to record, especially if they're alone, if there's not a partner with them, record the whole visit, because we all know, and I know that if I go to the doctor myself, half of what they say is lost before you leave the hospital.
Absolutely.
So if you record the whole visit, you can listen back and say, what actually did she say and what do I have to do? So I think that's a really important advice.
So having been involved in this for some time, I think it's fair to say that patients' levels of understanding does vary. Now, EUFOREA has introduced a lay language term, we talked about this a little earlier, which is Nasal Polyp Syndrome, and this aims to help patients initiate conversations about CRSwNP with their doctor, as we heard, of course, often in a very limited time setting. Let me come, if I may, Elke, you said right at the beginning, the idea of this, having something to hang your hat on, nasal polyp syndrome, was helpful to you.
Yeah, it's helpful to explain and to talk with friends and your partner and people around you that it's more than a cold. Yeah, because they think your nose is obstructed, you have a cold or something. But the meaning of a syndrome gives it more, impact.
And would you agree with that, Victor? Just in terms also about the chronicity, you're basically saying it's a syndrome. It's complex.
No, definitely. Having a right name that is easy to understand and pronounce by everyone is so important. We saw, I'm going to put my awareness hat now, we saw what happened with COPD, right? Very complex names. It actually doesn't work with, it does bad for awareness of the disease, right? Especially if in different languages. So obviously CRS with NP, that's a name that no one is going to remember and it's going to be so different in every language. So having one unified name for it is important, but we also have to consider, because there is also CRSwNP, sans nasal polyps, so we have to find a way to bring everyone in that, everyone in the community with or without nasal polyps under that name somehow, to not exclude those patients who doesn't have nasal polyp, but they still have chronic rhinosinusitis.
And Catherine, for you, obviously you can see this from both sides, as a patient and as a doctor. What do you think of the term, A, as a patient, and B, as a GP? Do you think it actually helps the GPs having that term, that nomenclature?
Yes, I do. because it makes it easier for them to communicate with the patients. I think the CRSwNP, they can understand as a doctor what the underlying pathology is and the problem, but the patients don't. And I think the fact that it also has the word syndrome in the title makes it so much more, have much more of an impact about the burden of the disease and the systemic nature of the disease. It's not just in your nose. It can affect so many different parts of you.
And Jeff, for you, obviously, as a very experienced patient, you've seen all of these changes going on. What are your thoughts?
The patients in this group and elsewhere, we worked with EUFOREA on thinking about different names and stuff. And it's difficult to come up with something that's inclusive. And I like the term nasal polyp syndrome. It's simple for patients to understand. It's simple to search for. And again, the word syndrome suggests like, oh, okay, stand back.
Well, so we looked at, I mean, they looked at lots of terms, didn't they, in terms of type 2 inflammatory disease, which again isn't very sexy, and I'm not sure that patients particularly understand that stuffy nose syndrome. Wytske, I know that not all medics love the idea of having a lay term. Your thoughts on that? Surely if it helps the patients, it must be a good thing.
Well, the good thing is that it's easier to explain. The less good thing, in my view, is that it says nasal polyp syndrome, and that implies that it's a disease of the nose. And it's not. It's a disease of the sinuses. And the sinuses are, well, half of your head. The nose is only, for most people think the nose is the tiny thing that sticks out of your head. So for that reason, you know, I think it sort of diminishes the impact of the disease on the quality of life.
That's really interesting. What are your views on that?
I think it's interesting what you say, because when I started 25 years, it was called nasal polyps.
Yeah.
And then it was changed actually by Wytske and the whole EPOS guideline group to chronic sinusitis with nasal polyps, which actually was a very great breakthrough, because therefore institutions, governments, healthcare, insurances understood that this was this kind of disease. We had one term, chronic sinusitis with nasal polyps. This was really breakthrough, because then companies started to invest in studies. So I think this was great. But nasal polyps was the original name, and maybe was for patients more interesting or more easy to use. The problem with nasal polyps is that, for example, in Dutch, it's also referred to this kind of adenoids. It's the adenoids that children that you can take away, and it never comes. Yeah, so
lymphoid tissue. Yeah.
So when you talk about nasal polyps, in where I live, it was always like, okay, but you can take it away in children. Oh, I got it taken away when I was a child. So there was a lot of confusion. And I like this nasal polyp syndrome, because it says nasal polyps. This is understandable, but the syndrome makes it, it's a serious disease. It's something, if you have that, oh my God, you have that, we have to do something about it. It gives you leverage for healthcare insurances, for everybody around to understand that we need something better than just a nasal spray.
And that's a brilliant point about focusing the mind, and particularly R&D development of new drugs, for example, because obviously you see it's multifactorial. In terms of educating, we heard from the GP earlier about it is a useful term. How does EUFOREA try and educate clinicians themselves?
There's a lot of material on the website explaining the everything from the pathophysiology to the management of the disease. And also there are courses. We just had a full day on new treatment options with biologics, and what are the possibilities and how to practically do that, for example. That's not only the theoretical background, but also what do you do in daily life with the patient in your room, and how to choose the best management for them.
Thank you very much indeed for the moment, everyone. Now, Shared decision making is a cornerstone of patient-centered care, allowing patients to actively participate in treatment decisions and align interventions with their personal preferences and values. And additionally, access to support systems and resources can greatly enhance patients' ability to cope with the challenges of living with CRSwNP and also navigate their care journey with confidence. The exciting news is today EUFOREA will be releasing the first edition of the Chronic Rhinosinusitis with Nasal Polyps patient guide.